Hello everybody, a very good evening to Catherine McEwan Live. We're very sorry about the technical difficulties at the start of the presentation. This has been the first time it's happened to us, but we don't expect the technical difficulties to return. So we will continue on as before. We've come back to a topic that was very popular a couple of months ago, and because so much has happened with coronavirus and vaccination, we're coming back to the topic for a second time this evening. So please get your questions in. We will try and answer as many as we can, even though we've got 5 minutes or so less than we'd originally planned. So it's a great delight to introduce two guests tonight. First off, I'm going to ask Vanessa just to introduce herself, please.
Thanks. Thank you for the invitation to join. My name is Vanessa Sanchez Shimizu. I'm a researcher I'm a geneticist looking at life-threatening infections in primarily children. I'm based in Paddington and Imperial College London. And we've been working on the genetics of COVID-19 disease.
Vanessa, thank you very much. And now it's a regular on Catherine McEwan Facebook Live. We've got Charlie Lees. So Charlie, over to you to introduce yourself, and thanks for doing a short presentation. While Charlie's doing his presentation, please do come in with your questions, which we'll go to straight after the presentation's done.
Well, thanks, Richard, and thanks to the Catherine McEwan Foundation for putting this on. I think it's really important that we do what we can to try and answer your questions and communicate as directly as possible. As Richard says, a lot has changed in the last, week, let alone the last month or two. So we'll do our very best to provide some very simple, clear messaging tonight and between us to answer your questions. So just to remind you, my name is Charlie Lees. I'm a gastroenterologist and professor of gastroenterology here in Edinburgh at the Edinburgh IBD unit. We've been working very closely with everyone around the UK to provide as clear updates and messaging around COVID-19 as it pertains to people with immune-mediated inflammatory diseases, including Crohn's disease and ulcerative colitis. And over the last couple of months, we've worked hard to bring together some sensible and very clear guidance about vaccination and what people should do. I'll give you the punchline already, and that is that we strongly endorse vaccination for COVID-19, and we urge all patients with inflammatory bowel disease to get vaccinated against COVID-19 when they are called for at the earliest possible opportunity. So, John, I'll just go through a few slides as an update. They've just got 8 or 9 different slides here, just to provide a brief update to where we are, what's happening, and where we're going, with some clear guidance, I think, from what we've produced in the UK. So first up, I've got the standard slide, stay home, protect the NHS and save lives. And I put this up really to remind us that, yes, across the UK, we are still in lockdown, and we are in lockdown for a very good reason. And I think that was brought home to us very clearly last month. And John, if you go to the next slide, you'll see in this graph of cases across the United States, the United Kingdom, Europe and Ireland, and you can see this huge spike that happened about a month ago now. This was felt very, very acutely in London and the southeast of England. It's been felt as it's rippled across the rest of England, Scotland, Wales, Northern Ireland, really across the piece. But this is also designed now to show us a bit of hope. The lockdown measures are really starting to work. Vaccination, there are some early signs that it's also starting to work as well. So this is just to say to everyone who has been doing their bit, which is pretty much all of us, to say thank you, because this is really making, I think, a difference already in terms of what is happening. And I do want to help provide an optimistic note as we move forwards. John, can you go to the next slide, please? So I want just to remind people that we have generated a risk generating tool, a web tool. You can see here in bold on the slide, ibdregistry.org.uk/COVID-19. This is Nick Kennedy, the mastermind for producing this guide that has been done in collaboration with the BSG, Crohns&colitis UK and the IBD registry. You can go in very simply and get your updated guidance on what risk categorization you are in. And that's important because those in the highest risk group equates to the shielding group. They are in the JCVI categorization number 4 for vaccination. And most people in that group should now have received their first vaccination. The moderate risk group is group 6, and hopefully these people will start to get vaccinated very soon as we move forwards. John, moving to the next slide, please. So if we move to vaccination, here is a summary slide of the different vaccines that have now been shown to be effective and safe for COVID-19. It's really quite extraordinary. This is a true miracle of modern medicine in many ways, of modern science, that within a year we have not just one vaccine that works, but we have 6 now across from the top: the Oxford Astra vaccine, there's a Janssen vaccine in the US, Novavax, Moderna, the BioNTech Pfizer vaccine, and the Sputnik 5 vaccine out of Russia. I've highlighted here the 2 key vaccines that are relevant for us in the UK. These are the ones that are currently in use. The Oxford Astra vaccine, which is a non-replicating vaccine. This is not a live vaccine, so it's good and it's safe for people with immune-mediated diseases like IBD who are on different medications, and I'm sure this will come up later in the Q&A. The Pfizer vaccine is an mRNA vaccine. This is similar to the Moderna one, which we will also be getting online in the UK soon. And as we know, these are being given by a slightly delayed schematic in terms of timelines across the UK, which is slightly different elsewhere. But the early evidence is that this is the right thing to be doing, and it is effective. So, John, the next slide just shows you the different vaccines. On the left-hand side here, I'll try and keep this very simple, is a schema of the SARS-CoV-2 virus. This is the virus, of course, that causes COVID. And you can see on the outside these blue lines. These blue lines represent the spike protein. And the vaccines that we have so far are all about giving the body the spike protein without the rest of the virus, and then the body then generates an immune response against that. It remembers that, so that if you see later the whole of the COVID infection, the SARS-CoV-2 virus, if you get infected, the body can handle this really effectively. And all the data shows that these vaccines work very, very well. And most importantly, across all the trials, no one who has been given the vaccine in the active vaccine arm, remember these are mostly placebo-controlled trials, no one has died. So these vaccines look incredibly effective at producing severe COVID infection and death, and there is significant evidence emerging that they also prevent milder illness as well as preventing the virus from transmitting. So this is in the middle, the Oxford vaccine, where you can see the spike protein is on this adenovirus vector. It's not live, so you can't catch COVID from this. And the mRNA is slightly different. We just give the code of the SARS-CoV-2 spike protein, and then the body recognizes again. So let's keep moving on, John, to the next slide. I would like to say that whilst we can argue that perhaps the UK's response to COVID has been suboptimal at times, one of the things that we seem to be getting spectacularly right is the vaccine rollout. This is a huge credit to all the volunteers, all the GPs, all the nurses who are delivering this across the country. It's fantastic to see. You can see here vaccination and how it's rolled out per 100 people of population. You can see Israel's way out the front from their centralized approach, which is really incredible to see. And that's where the earliest data is showing that vaccination works. The United Arab Emirates is a slight outlier because they're just offering any adult to come forward and get vaccinated. They're not trying to prioritize. And you can see how well the UK is doing compared to others. And we have seen the targets. I don't need to go into that in any more detail. John, the next slide, please. So we have produced, and this is huge credit to Nick Powell, who's led this from London, a guidance document from the British Society of Gastroenterology and Crohn's and Colitis UK about our recommendations for people with IBD in terms of vaccination. This is very similar to the international guidance that was released last month, and also to the ECHO guidance as well. These key messages are very clear. We strongly support vaccination for people with inflammatory bowel disease. The risk of vaccination in people with IBD is anticipated to be very low indeed, and no different from the background population, so it's very low. In patients taking IBD, this is point 3, who are on immune suppressive drugs, including biologics and small molecule inhibitors, there is a theoretical risk that the vaccines might be slightly less effective. We are investigating this. What we want people to say to people is this does not mean you should not take the vaccine. In fact, please take the vaccine at the earliest possible opportunity, i.e. when you are offered it. It is possible we will need to look at some mitigation measures further downstream, including giving top-up doses to some people. But this is far from certain, and this does not mean that the vaccines aren't safe. Okay, so next slide, please, John. We're moving to the end of this. I just wanted to highlight and introduce to you another huge success story across the UK, and this is the Clarity study. Some of you will have been involved in this. This is thanks to Tariq Ahmed, Nick Kennedy and Claire Bouchy in Exeter, and Nick Powell, who I mentioned to you before. And what Clarity has done, if you move along again for me, John, to the next slide, what Clarity has done is recruited an incredible 7,000 people with inflammatory bowel disease in the 12 weeks leading up to Christmas who are being treated with either infliximab in the green here or vedolizumab. These are two of the drugs that we use to treat Crohn's disease and ulcerative colitis. And what we're looking to now to understand is how the response to COVID infection and the response to vaccination is different in people on different medicines. And we look to get some results from this study very, very soon indeed. It's a huge triumph to the IBD community. It's a world-leading study. I want to flag it now because you'll be hearing some outputs from this study very soon. John, the last slide I've got here is just to show you one of the publicly available outputs from this study already is looking at the people who have antibodies against COVID. These are people who have had COVID infection across the UK. And it just shows, as you would expect, the hotspots in London, the southeast, the north of England, showing that we've been relatively spared in Scotland and other parts of the UK. So that's it from me, Richard, as an introduction. You can kill those slides now. Thanks, John. I hope that helps set the scene a bit. I want us to feel optimistic now as we have these dark February days still ahead of us, that vaccination is working, the rollout is going really very well indeed, and we're looking after our IBD population through the research that we're doing.
Charlie, thank you very much, and absolutely brilliant and very up to date, and I have to say very reassuring summary. Lots of questions have come in. Thank you everybody for all the questions that you've sent in already. I want to, just before we go in, so there's loads of questions about vaccination and treatment and things, but just before we go into that, just Jacqueline Grant has asked us a question just about treatments themselves. So infliximab can be used for treatment for severe COVID. What does that mean for COVID's patients treated with this medicine and similar medicine? So great question, Jacqueline. Can I ask you both just to start with that question before we go into vaccination? Charlie, do you want to start, and then Vanessa?
Yeah, so there's been the other, I didn't mention this at all actually, and Vanessa may comment, but there's been huge advances in the science of COVID in the last year. It's been absolutely extraordinary, and some very big studies, including the results that have come from the Recovery study out of the UK, looking at the effectiveness of different treatments for people with severe COVID. Now, with severe COVID, there is an immune response, and I'll let Vanessa talk to this in a minute, that means that the immune system is going into overdrive, and that likely contributes to a lot of the reason why people get very sick, end up on ventilators in ITU, and unfortunately die. Some of the treatments that have been shown to be effective are similar treatments to those that we use for inflammatory bowel disease. They're slightly different. So tocilizumab, the name that's tripped up many a politician trying to announce these results, has been shown to be effective. We know that steroids, so dexamethasone, which of course is similar to the steroids that we use to treat active inflammatory bowel disease, have been shown to be effective. We don't yet know if infliximab or adalimumab would be effective. There's a lot of thought that they might be, and there is one study ongoing to look at this, as well as some of the JAK inhibitors too. So we don't know the answer to that yet. Thankfully, all of the data that we have so far suggest that the anti-TNF drugs do not increase the risk of getting severe COVID, which is reassuring. but perhaps Vanessa can give some comments about what's happening with severe COVID when the immune system is going into overdrive.
Yeah, I mean, I think, Charlie, you've covered most of what the question was asking for, but indeed, most of the treatments that have been put across as being effective in severe critical COVID disease has really focused around dampening down the inflammatory response. And we can really dissect critical COVID disease into sort of two stages. One is this initial phase where you have what we think is inability to control the viral replication. And this causes the initial sort of pneumonia. And then from then on, you basically get this engagement of a normal immune response, which is an inflammatory response to get rid of the viral infection. And in most people where this isn't a problem and people resolve this, that inflammatory response will clear up and things will be fine. But in the people who then present critical disease, this stage goes into this hyperinflammatory overdrive, and the body is unable to control that inflammatory response, and it actually becomes quite detrimental to yourself. So it makes sense that dexamethasone is, a broad steroid that actually brings down all these inflammatory markers has been quite effective, and one in IL-6 too. So the toxilus. I can't say it actually. The anti-IL-6 drug also is targeting the same pathways. And infliximab is also one of these pro-inflammatory cytokines. So it, from a logical point of view, it would make sense that one would propose it as a potential treatment. But as Charlie said, this needs to obviously be tested through rigorous clinical trials.
Thank you very much. Very helpful, and good to see Vanessa as well as politicians can't say some of the medicines. So I want to move into some vaccine questions now. So Ella Wilkes, thank you very much for your question. Very good, very practical question here. So Ella has been given lots of different Crohn's disease medications, and she's had reactions to those medications. So she wants to know, in light of her personal circumstances, is the vaccine safe for patients?
So I think the answer to that will be, so we're trying to avoid the word safe. These vaccines are very low risk. There will be occasional people that have a true allergic reaction to some of these vaccines, an anaphylaxis type reaction. But this is extremely rare. And I think all of the data that so far show that these events are somewhere in the region of 10 or 11 for every million people that receive a dose of the vaccine. And these are true anaphylaxis responses to something that is in the vaccine, and that shouldn't be an issue if you have had problems with IBD medicines. So unless you have had a true anaphylaxis response to medicine, in which case you should discuss this, it should not be a problem moving forward. So there's lots of reasons why people don't tolerate IBD medicines, and those are not reasons not to go ahead and get the COVID vaccine.
Vanessa, anything to add from your point of view? Or?
No, exactly that. The only real risk with vaccines is the anaphylaxis, and we know that's on the order of 5 in a million. So it's exceedingly rare.
So the risk of COVID far outweighs the risk from any vaccination. I think we're all agreed there, so that's great. There are a lot of questions on a very similar theme, so I'm going to start with one and probably ask you for quick answers to a few of them, because they are asking important questions, but all along a similar theme. So Georgina has asked us a very good question. For patients on immunosuppressants who have had the vaccination, should they have an antibody test after they've had the vaccination? And how would they go about this if they should? So, Vanessa, do you want to start with that?
I think it would be reassuring to get an antibody test to make sure that one has mounted a proper immune response. Indeed, actually, I don't know what the pathway is through the NHS to be able to get that sort of testing done, but I would imagine that would be something hopefully that can be provided by primary care. I may actually, Charlie, maybe you can speak to that a bit more.
Yeah, so that I think would be the most sensible and ideal approach. We don't yet know is the honest answer. So we don't yet know what kind of provision is going to be made for this as we move forwards. And it will need to be some way down the line anyway, after having had both doses of vaccine before this becomes relevant. So we will come back and update people on this as plans become evident. It makes intuitive sense that we should be checking this later, so it's a really sensible question. At the moment, there is no provision for it, so please don't go and phone up your doctor or speak to your IBD team and say, can I have an antibody test? These tests do exist, so we can use them in the short to medium term through research channels so that we can understand how people mount a response to the different vaccines on different medications in different circumstances, and that will then feed the need for that to be the case. Because if we see that everyone's mounted an excellent response, then we won't actually need to do it.
So it was the perfect question. I'm sorry, we just don't have the perfect answer yet, but we're certainly think it's a good thing to do, and we'll certainly follow up. Just don't ask yet. Okay, Eileen Grant, thank you for your question, Eileen. I've had the vaccination and about to start combination therapy. Will I still have good protection? Charlie, you want to start with that one?
Yeah, so the simple answer to this is that we do not yet have any evidence that any of our medications affect vaccine effectiveness. So that is the starting point. So we need to understand what will happen to people on different medicines, and we will look at this. In addition, there will be the questions of timing, and I think the bottom line so the answer to your question is, I hope you will have an adequate response. We don't quite know, but please just go ahead with everything anyway. You should get the treatment that you need for your IBD when you need it, and you should get the vaccine at the earliest possible opportunity. So as long as you follow those two rules of thumb, and be reassured that we will pick up things if we need to down the line as data becomes available.
Vanessa, anything you want to add?
No, I think Charlie said it all.
Okay, so Caroline Brocklehurst has asked a similar question. Will vaccines be as effective if you're on biologics? So I presume that's a similar answer to you just gave?
Yeah, I think so. We don't. So and it is worth bearing in mind, of course, that we use a number of different biologic medicines, and there are slightly different theoretical risks between of lower vaccine effectiveness on the different medicines. But please be reassured that we see nothing of any concern to suggest that the vaccines will have any different safety profile depending on what medicines you're on. So go ahead at the earliest possible opportunity.
So a couple of questions now, and a kind of pediatric theme. So Angie Blackshaw, thanks for your question. My son is 16 and was given the Oxford vaccine last week, but the guidelines say it's for over 18s only. My doctor told me this was okay. Is it really safe for the under 18s? Either of you want to pick up on that?
Well, so I believe that there has been a trial for children started just now from the six-year-olds to 18-year-olds. So that's being tested. And yes, these vaccines have been tested, have been specifically tested in a specific age group. So I guess the answer is the clinical trials data has not shown, we don't have the data for that yet. Given the fact that the child is 16, which is quite close to the 18-year-old age, I think one can assume that in most cases vaccines have a similar response. So, but the short answer is we don't know until we have actually clinical trials data. but again, like I said, there's a clinical trial going on now addressing this specific question for over 6-year-olds. And we'll only get proper advice through that. Charlie?
Yeah, Richard, you might want to comment actually just generally in terms of your thoughts about pediatric vaccination and where that's going and how you see that affecting IBD patients in particular.
Sure. I mean, I think we use lots of things which are licensed for 18 and over in children, and we always have to weigh up what are the benefits of the treatment, be it a vaccine or something else, compared to the potential risks. And I think in this situation, the risks are very, very low, but the potential benefits are high. Overall, patients and people under the age of 18 have a very, very low risk of any significant infection for coronavirus or complications. And that's why they will be the last ones in the general rollout of the vaccine, probably won't get it this year. But it's important to say that if you're offered the vaccine over the age of 16, I would suggest there is no reason to suspect it isn't as likely to work as someone of 18 or 19. So I would say it's as likely to have the same side effect profile in those ages of patients and to go ahead and take it. Under the age of 16 and younger patients is a slightly different scenario. And maybe answering a question from Lisa Cook. Lisa, nice to hear from you, and thanks for your question. Will children under 16 who have Crohn's disease be invited for the vaccine? The answer is not at the moment, but things may change over time. So the vast majority of children under 16 have such a low risk that they are not a priority for vaccination. And that's good news that they're very unlikely to, even if they get coronavirus, get any significant problems with it. So it's a good news answer, but not yet.
So Vanessa, you've been doing a bit of work, I think, haven't you, on the very, very rare multi-system disorders that kids get, but it's extremely rare, is it not?
Yeah, so we have estimates that it occurs in 1 in 100,000 cases. So this is really exceedingly rare. So yeah, it does happen, but it's really in the very exceedingly rare category.
And that's important, I think, Richard, to emphasize, isn't it? Because we've talked about this last year when we were on together, and we've got so much more. Unfortunately, we've got so much more data because the pandemic has gone on so long, and because the second wave has been so big. So I think it is worth just reiterating many of these points that we made 3, 6, 9 months ago, which is that children are extremely low risk. Patients with inflammatory bowel disease do not appear to be increased risk. None of the key medications that we use, with the possible exception of prednisolone of steroid therapy, seem to increase the risk. So reassuring messages that we've said time and time again that seem to be borne out as we've got additional data.
Yeah, if I can add another number there. So if you look at all the ICU admissions due to COVID-19 in the UK, it's between 1 and 2% is children. So this is exceedingly rare. And again, mortality rates within that is even smaller. So it's a very, 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 we're lucky that the children are protected.
Yeah, I agree with that. So Alexandra Clark, thank you for your question. Alexandra takes 50 milligrams of mercaptopurine and Humira weekly. She says she has a lowered immune system because of that. She's getting the vaccine tomorrow. Do you think this will help protect people with me, like with IBD? I have Crohn's.
So to say, Alexandra, great news that you're getting the vaccine tomorrow. Hope it goes well. I'm sure it will. And similar to before, people who are on the medicines that you're on, that there is this theoretical risk that your body will mount a slightly lower response to the vaccine than people who are not. Having said that, this is extrapolating from other vaccines like the flu vaccine where we have seen this signal before. But it's worth emphasizing that these COVID vaccines are really, really effective. It's extraordinary. So we're lucky, number one, that kids don't get bad COVID. That's a huge relief. We're really lucky, number two, that through the scientific advances, these vaccines work extraordinarily well. And so I'm quite optimistic, actually, that this theoretical risk will turn out to be much less of a worry than we thought about. I don't know if you want to comment, Vanessa, on the effectiveness of the vaccines that we have.
Yeah, I mean, like you said, you highlighted the effectiveness of these COVID-19 vaccines have been, I mean, absolutely fantastic. 95% efficacy is great. So that's extremely reassuring moving forward. And yeah, I think the message is that if you're offered it, you should take it because it's extremely low risk.
Anna Reid asked a related question. You've answered most of it, but she asked specifically what the difference between the effectiveness was of 1 dose and 2 doses of the vaccine. And she also asked about if you're on biologics and immunosuppressants as well, but I guess we can't answer the second part. But what about the first part of the difference between 1 and 2 doses?
So I can maybe speak to that. There's ample evidence for the different vaccines that are out there, but I'll speak specifically to the Pfizer one, which has been very well studied. And so after the first dose, we know that the first 10 days after your first dose, you're still mounting that optimal immune response. So you're not fully protected within that first 10 days. That's sort of your body working up to it. And you only really start seeing the effect of that vaccine and the protectiveness after day 10. And then on that immune response grows with every day. So at the 10-day point, the initial study suggested that it reduced severe disease by 53, just cases by 53%. So it was 53% effective. And then after the second dose with the booster, then you're up at 95. So there is the first dose does actually do something. We do have to take into consideration that those first 10 days you're like not having been vaccinated at all because your body's working up to that, is making those antibodies to neutralizing antibodies. So yeah, there is a gradual increase up to I think day 21, where then you get your booster.
Great, thank you. Ali Smith has said her son is 19 and taking fortnightly Imraldi, so that's adalimumab for everyone. When should he receive the vaccine? So where is he in terms of priority? Charlie, you touched on this, but just to reinforce that.
Yeah, so if you're in any doubt, go to the website, ibdregistry.org.uk/COVID-19, and you can go to the risk calculator to see that. Importantly, actually, that will also allow you to print out the result. You can take that to your GP if necessary. From the information you've given, your son is most likely to be in the moderate risk category. That equates to people who are not shielding. We say moderate risk. We don't actually think it does increase the risk now based on the evidence that we're seeing, but it does classify you in that group that would be JCVI group 6, and the government is getting to those groups now. So I would hope that you will get an invitation for that first dose of vaccine within the next month or so, probably by the end of April at the very latest, but hopefully much sooner.
And Anna Reid has asked an important question. It's about a specific medication, but perhaps you can comment generally about people and when they take their medicines around vaccination. So Anna, thanks for your question. She's due her vaccine near her ustekinumab injection. Does she leave a space between the vaccine and the medication?
No need. Just go ahead. You can take them on the same day if you want.
And that applies to all medications? All
medicines, correct. We're keeping this advice really simple. So you can have it on the same day as your infliximab infusion, your adalimumab injection, your ustekinumab, your vedolizumab, your tofacitinib, and your tablets, whatever you're doing. Just it doesn't matter as far as we're aware. So just go ahead. Keep it simple.
Okay, great advice. Thank you. Vanessa may come to you with this next question. So Anne McLeod asks, any idea when the COVID vaccine could be licensed for under 16-year-olds? GP made an appointment for my 15-year-old daughter, then cancelled it at the last minute. So you told us about the trials which are ongoing. When would we realistically think we might have an answer from those?
I'd probably say by the end of this year, realistically. Just looking at how long it took for the adult trial, and we need the numbers. So I would imagine by the end of this year we would hopefully have some guidance over that.
Yeah, I think that's probably right, and the chatter is, it's quite interesting actually, because you could ask why at all, because we've talked about how low risk it is, but I think the hope is that by showing the vaccines are safe and effective in young people, that you can give children a COVID vaccine as part of their vaccine workup ultimately, and that may then provide lifelong protection against COVID and potentially other coronaviruses too.
Yeah.
This is a great, very insightful question here. It's perhaps slightly controversial, but Alison Starkey, brilliantly well thought out question. So she says, if my son's no more at risk than his healthy peers, why does he need the vaccine then? So if you're an IBD patient and the risk is no greater, and that's what we said at the top with treatment, why does he need the vaccine before them then? I'll let you both answer that.
You go first, Vanessa.
That wasn't very fair. Charlie,
I was being gentlemanly. I would happily go first if you would prefer.
I prefer to go, but only because I don't know. I'm not an expert around IBD per se, so I think that really speaks to more about the particularities around that.
So I think I answer this as a more very general point, is that why should anyone get vaccinated if they are at low risk? So why should ultimately 20 and 30 and 40-year-olds get vaccinated? And really it's to protect everyone in the community, because we know that for this to really work, so that we can reduce transmission to zero, what we need to do is reach herd immunity. And we know that the only way to get to herd immunity safely and effectively is through vaccination. There is no herd immunity for COVID via natural infection. We know that's just totally ridiculous. So if you are of low risk with IBD, you are getting vaccinated in a way that helps to protect everyone around you. I guess the one, so I'll let Vanessa add to that in a minute, but I think the one specific thing I would add is that there are perhaps certain circumstances, if you have inflammatory bowel disease, where your risk may change over time. We're very conscious that IBD is a very dynamic state. So you might be, we still don't understand all of this, but if you end up needing to have steroids, for example, or you end up in hospital, your risk from getting COVID might actually increase a bit at a later time point that's totally unrelated to anything else, but might be because your Crohn's disease or your ulcerative colitis has flared. And we know that these are very unpredictable conditions. So by protecting yourself now when you are well, then you are giving yourself that sort of extra chink in your armor to help hopefully fortify everything, your body and your responses for later on.
I don't really have much to add other than I think that's seems.
I've got another question coming for you just in a minute, Vanessa, don't worry. But Charlie, can I just take a related question to you first, and then I'm coming to Rebecca. So Carol Millard has asked a very good question. Thank you, Carol. I have a raised ESR and already have inflammation. What are the risks of the vaccine? So can we talk about that specific situation, but generally, if there's inflammation going on in a patient with IBD, what does the risk of the vaccine change?
I don't think it does. I don't think there's any evidence that it does do that. And so I would just go ahead as planned. We think, so if we go back to the risk of COVID, there are two things that we think probably overall do slightly increase the risk, but we still don't actually know this. One is we think is higher doses of systemic steroids like prednisolone, and the other might be people who've got very active disease. And those two might actually confound each other a bit. But my suggestion to you is that neither of those things should change the risk of the vaccine. They should not also change your immune response to the vaccine either. I don't think there's any evidence or suggestion of why that should be the case. So please be reassured and just go ahead and get it done. And just to say, I'm sorry to hear that you've got that persistently high level of inflammation, and I hope that your team are looking into that. Because there are lots of ways now which we can, with new medicines, help to reduce that inflammation.
Perfect. Vanessa, here's your question. So Eileen Grant, thank you, Eileen. Both my daughter and I have Crohn's disease and had the Oxford vaccine. My daughter felt ill afterwards and was told her immune system was kicking in. Does that mean my immune system didn't respond as I had no reaction, so she felt well?
No, I don't think, these are sort of anecdotal things, and there's no correlation really with your immune response and how ill you feel after vaccination. So I wouldn't take that as a marker of the vaccine not having worked.
Yeah, I think that's absolutely right. People are going to be very, very different. So there's an important point here as well, Richard, I think, which is that most people, not everyone, but most people feel something after they've had the vaccine. And these aren't really side effects. These are really just the effects. It's not necessarily a sign the vaccine is working or not. So if you don't have them, you shouldn't worry. But most people will get something to do with a sore arm. Some people will feel a bit feverish. Some people will get a bit of a headache, for example. Anecdotally, the people who have had COVID already might have a slightly stronger, more robust set of reactions or effects of the vaccine. And so some people would have had COVID without having any symptoms, but might have some effects otherwise. But you could easily have not had COVID and have effects, or have had COVID and have no effects, and have very similar antibody levels against the vaccine later. So please don't worry about it.
Great. Okay. These questions may have been answered already, but they're two related questions. So just to hammer home some messages, I think. So Sue Rubenstein de Massey, Sue, fantastic name and great question. So she's asking about, she's been told by one of her doctors to space out her biologics by a week around the vaccine, and another one says 2 weeks. A third one says it doesn't matter. What's the correct answer?
Third one, doesn't matter.
Yeah, okay. And Caroline Brocklehurst has asked very similar question. I was given the Oxford vaccine today, due to get a loading dose of adalimumab on Monday. Is it safe to have them so close, and will the effectiveness of either be decreased by having them so close together?
Yeah. No, go ahead. And your doctors are starting on adalimumab because you need it to control your disease. So, it's great that you've managed to get vaccinated, and it's great that you're starting on a new therapy. Good luck with both.
So a question that we haven't really touched on yet is from Sinead Martin. I hope I said your first name correctly, but thanks for your question. So we've talked about patients who are on biologics or immunosuppressants for their Crohn's disease. But if you're not on drugs for Crohn's disease, so I presume maybe a mild type, or you've had an operation and now no longer need medication, when should patients like that expect to get their vaccine?
Yeah, I think that most of those people who are in the sort of low risk category will just be called for as per the background population. And so that's JCVI group 9, I think, I'm afraid. But actually, I would just go back to what I said in my opening preamble. We have an incredibly efficient vaccination program going on in the UK, thanks to the NHS and the way it works, thanks to the way that the annual flu vaccine program is delivered, and thanks, I think, just to a really good set of circumstances that work really well, right the way from procurement to the way that we've set up the trials to demonstrate that the different vaccines work, etc., etc. So people who are in the low risk groups will still, I think, expect to get vaccinated sooner rather than later. I'm not sure what the latest estimates are, but I would be hopeful that almost every adult in the UK is offered a vaccine by the summer.
Cool, thank you. Vanessa, perhaps a couple of questions for you. They're both really on the same topic. So Carol asked a question, and also Lorraine. They're both about concern because they have allergies to specific medication, one to lithium and one to penicillin. They both had allergic reactions to it. They're worried about the potential side effects of the vaccine because they've had these allergies to medications. What what should your advice be to them?
Actually, so that's not really my area of expertise, really, but I think when this will be asked when you're going to be given the vaccine. And anyone who's had any history of anaphylactic responses to anything will be treated separately. When you're given the vaccine, you're always asked to stick around for 15 to 30 minutes anyway, because that is when the response will happen. So people will probably monitor you. But actually, Charlie, maybe do you know a bit more about what the advice would be around that?
So I think you fit that pretty much perfectly there, Vanessa, actually. The other thing that we've learned now from these allergic anaphylactic reactions to the vaccine is that I think almost all of them have happened within 10 minutes of having had the vaccine. So that 15-minute window is safe. So no one has died from the anaphylaxis. They've nearly all happened within 10 minutes of having had the vaccine. So the system is designed to stop that happening. Now, a lot of people have allergic reactions to things that are not anaphylaxis. There are, I think, very robust systems in most parts of the country now to allow people to discuss this. So if you are in any doubt, get in touch. There should be a way to contact your local vaccination service so that you can ask these questions specifically. If not, going via your GP will probably put you in the right place to get a definitive answer. But, really it's, have you had a true anaphylactic reaction to a medicine? It's not, I had azathioprine for my Crohn's disease and it made me feel sick, so I had to stop taking it. Or it's not, I had a rash when I took penicillin once. These are not things of any concern at all. And typically it's people who would carry around an EpiPen because they had an anaphylactic reaction to something.
Great, thank you very much. And Lorraine, I hope that answers your question too, because it's very similar to those two which were already asked. We've not touched on perhaps some of the controversy of vaccination. So Tracy DeMarco, thank you for asking this. When Pfizer suggests 21 days between doses and we've been moved to 12 weeks, my 16-year-old son had his first dose of Pfizer last week, which is right. So is it 21 days or 12 weeks? Vanessa, do you want to answer that one first?
Yeah, well, so again, we go by what the clinical trials data has proven, and what's been proven was the 21 days. However, what we do know from our experience with other vaccines is that there have been other studies, not using this particular vaccine, but with other vaccinations. But the immune response works in the same way in terms of mounting a antibody response. And in those other studies, they've shown that actually it's optimal to give a second dose or a booster 2 to 3 months after the first one. So in a sense, I guess the UK government is extrapolating that data to fit. There's a balance to be struck here as to trying to get the entire population vaccinated versus also giving optimal protection. So they have opted for maybe the more controversial route of saying we're not going to stick with the 21 days, we're going to do the 3 months and trying to get the first dose out to as many people as possible. At the same time, there has just been a paper that's come out to reassess the efficacy of the first dose of the Pfizer vaccine. I just mentioned to you that after the first dose, the first 10 days doesn't count, and that 53% protection actually in the initial paper was counting those first 10 days. So actually, if you remove the 10 days and don't count that into the protection, you get about 90% efficacy, I think is what they suggested after the first dose. So if you count from day 11, which is when you're supposed to be actually protected from that vaccine, you are actually protected. You have 91 or 90% efficacy. So that's sort of a new data that has resurfaced now, supporting the idea that actually, we will be protected even though it's a longer interval to wait.
I think that's right. I would just add very briefly to that this is a public health decision that the UK government has made. And I think the early signs are that it's probably been the right decision. We are way ahead of others in terms of getting some, at least some protection in a lot of people. And I think there is very little to suggest that this will do harm, and I think it will turn out to have done a lot of good. So please don't worry.
Perfect. Okay, I think we're probably coming towards the end of these questions. I apologise, I did not get round to everybody's questions, and for people who asked questions which were not related to coronavirus vaccination, I apologise not for coming to questions on shielding and medication and other things, but it wasn't really the focus of things tonight, and I wanted really to concentrate on the topic that we planned to discuss. So any final messages from Charlie and Vanessa just before we close?
Go on.
Okay, I guess just a few words to say that I think we should be really feeling optimistic about things. I think Charlie touched on this initially, but it is absolutely incredible how much we have learned and how much science has brought us forward in this past year. It's crazy to think that a year ago we would have predicted that, you know, there would be millions of people already vaccinated with this with a vaccine against coronavirus. So I believe that there is light at the end of the tunnel. Also, science has also provided us with new treatments so that we can better manage the patients in ICU. So I think really things are looking up.
I agree with that, and I just wanted to add to that I know from my clinics and I know from our lives that, you know, a lot of people are struggling out there at the moment. This process, this lockdown, this whole pandemic seems to be going on forever. There've been some very long nights and dark days, and it's felt like there's not obviously been a route out of things. So the vaccination program is our way out of things. People with IBD are not at increased risk from vaccination. Please go ahead and get vaccinated at the earliest possible opportunity, and please come back to us for in the future, and we can provide some further updates on how that's going and how specific that's affected people with IBD. So in the meantime, I would just say to people that, you know, please try and look on the bright side. And if you are struggling a lot, then please don't struggle in silence and reach out to someone, give your GP a phone. There's lots of points of contact if you are struggling. Thanks, Richard.
Thank you very much to Charlie and Vanessa for answering all of the questions very comprehensively. I've got the tofacitinib problem, Vanessa. It's been fantastic. Please like the page. Please share it on Facebook. I'm sorry again to everybody who I didn't answer their questions. Jackie, especially, for you've made comments on me. I try and get as many questions in as I can that are important to as many people. The next session is on the 4th of March, so mark your diaries for then. All join in. Thank you very, very much for all your brilliant questions this evening. Absolutely fantastic. Goodbye and get vaccinated.
Thanks, everyone.
Bye.
Bye-bye.
Bye.
Bye.